is it the next person's coming at 2, right, Claire? Yep, we have until 2, till the next testimony.
Thank you.
Okay, and we are live. So welcome back, Dr. Swanson. Sorry, everyone, for the technical difficulties. So we're going to start from the top, Dr. Swanson. If you want to start over, that would be great.
Thank you, and good afternoon, everyone. My name is Jeffrey Swanson. I'm a professor in psychiatry and behavioral sciences at the Duke University School of Medicine and a faculty affiliate of the Wilson Center for Science and Justice and the Center for Firearms Law at Duke Law School. Thank you for the opportunity to join you today and to speak about extreme risk protection orders. And I was just saying, it was just sobering to me to be talking about this today on another day when we're just reeling from the news of another mass shooting. And it's sort of a uniquely American recurring nightmare. These incidents just are so disturbing and so terrifying and so irrational, and they're just everything we don't want ordinary life to be. And I like to remind myself and everybody that on the day of a mass shooting here in our country, and on the day before and on the day after that, an average of 130 other people die as a result of a gunshot all around the United States, and suicides and domestic violence incidents and gang shootings and, just arguments gone bad between angry, aggrieved and intoxicated young men. And we don't hear about those. And at the core of every one of those statistics, and I have 3 of these stories in my own extended family, is a human story of a life cut short and loved ones left behind. And it's just a tragedy in its own right. And it rips through families and communities across the generations. And that's the thing that motivates me. And it keeps me going as a researcher, trying to bring research evidence to bear to find our way to interventions, policies, and laws to try to do something about this at the state level and at the federal level. As you know, there's no one solution to gun violence in America or in the state of Vermont, and you're thinking about some of them. Some solutions are off the table. We can't just broadly limit legal access to guns, as many countries do. We live in a country with a deeply entrenched gun culture, constitutionally protected individual right to bear arms, and this is more so in some. Gun culture is more entrenched in some areas of the country than others. But gun violence, in my view, is a public health problem. It doesn't have to be a political issue. And I was heartened by the enactment of the Bipartisan Safer Communities Act at the federal level last summer that provided funding for states to do, among other things, an ensemble of reforms, including extreme risk protection orders, or ERPOs, or red flag laws, such as one you have in Vermont. And I think that shows that Americans can work across the political spectrum and can work together to start solving this problem that's this big and this complicated. So I'd like to say just for a few minutes some things, and maybe you know this, maybe not, but just some things about the logic and the rationale and the legal design of extreme risk protection orders. And I'll just use the term acronyms for short, why they are an important piece in the puzzle of gun violence prevention at the state level, how they work and how they might work better, and why we really need to focus on implementing them at this point. So it's often the case, prior to a gun violence tragedy, that somebody, it's often a family member or a household member, was alert to an escalation of extreme anger or threatening or suicidal behavior on the part of somebody with access to a gun, or who could legally go and buy one. Would pass a background check if they went to buy a gun. And so an ERPO is a versatile legal tool to act on that information about risk ahead of time. So you don't have to look back through your retrospective scope and say, well, why didn't somebody see that coming? You use information that's available around someone. People might know this. To prevent harm. And it's a civil restraining order. It's time limited. It's not criminalizing. It temporarily separates firearms from a person who poses a high risk of harming others or himself or herself. And these orders offer due process protections and respect the Second Amendment. And importantly, they're supported by majorities of Americans, majorities of gun owners, and they save lives. So how do we know that? Well, we need more research, but the emerging research is strongly suggestive that these laws can save lives. My colleagues and I conducted the first 2 evaluations in the first sort of precursor states in Connecticut and Indiana. And I can go into detail, but our studies estimated that for every 10 to 20 risk-based gun removal actions, one life was saved by averting a suicide. Now we have new research from 6 states, California, Washington, Colorado, and Connecticut, and it finds that 1 in 10 extreme risk protection orders were involving a person who had threatened a multiple victim shooting. So we don't know for sure that, all those would have turned into a mass shooting, but we do know that they're being used in cases where there are those threats, school shootings and so on. And again, like when we hear about a mass shooting, I mean, it's a small fraction of all of the, firearm deaths and even the gun homicides, but that's when we focus on this and kind of seeps into our national conversation, our public imagination, and everybody wants to know, well, why did he do that? Why did that person go out and massacre strangers? And it's it seems like a fair question. It's a hard one to answer, to say, well, that was an angry, alienated, isolated, and resentful man. That's not really a satisfying answer because that describes lots of people who aren't going to do that. And to say they're mentally ill is also not a satisfying answer. Fixed mental health is a great slogan for a different public health problem. It just intersects with gun violence a little bit. And so the state of science comes up short on the why did he do it question. But there's a different question we can ask, and that is, if we want somebody to stop so many people from dying, what more can we do to ensure that people inclined to harm others or themselves don't have access to a firearm, this really efficient killing technology at that time? That we have some answers to. So, in our country, basically, there's kind of, given that we have so many guns and a constitutional right to bear arms, there's sort of 2 ways in general that the government limits access to guns by high-risk people. And the first one doesn't seem to be working too well. That's to enact and enforce laws to prevent people, categories of putatively dangerous people or law-breaking people, such as people with a felony conviction, from purchasing or possessing guns. But that's just not enough because the prohibiting criteria are sort of too broad and too narrow at the same time. They don't always correlate very well with real-time risk. So you have lots of people who are prohibited and probably won't do anything violent or harmful, and then you have people who aren't prohibited who can pass a background check. So, and we don't have universal background checks, and the records sometimes aren't complete. So the second approach is this ERPO approach, which I think is, in our country, it's like a Swiss Army knife of gun violence prevention because it's a versatile legal tool. It removes firearms for a while from a person who's behaving dangerously, irrespective of why they're posing that risk. So, we partnered with colleagues in Connecticut to conduct that first evaluation that I mentioned, called a risk warrant law. It's been on the books since 1999, but it was hardly used at all in the first 5 years of its existence, and I think there's a lesson there. And it gradually came into use, and by about 2013, there were 762 cases, almost 800 cases to look at. And that's what we did. We found that about 2/3 of those cases involved a suicide concern. So even though the law was passed as a legislative response to public outrage over a mass shooting at the Connecticut State Lottery headquarters in 1998, it was used mostly for suicide concerns. It could be, we're worried about our granddad who's bereaved and he's not himself, and he's has all these guns, but he's not broken the law, and he's not mentally incompetent. But and I have such a granddad on my wife's side of the family who died in that way. So there are many kinds of situations and scenarios where this can work. So in about half of the cases, a call to the police came from concerned family members or acquaintances who had initiated this risk warrant petition. And then in some of the states, now family members can do this directly, and I think it's a good idea, and I think Vermont should incorporate that into their ERPO law. We found that nearly half of these individuals had a record in the public behavioral health system in Connecticut, often for a substance abuse problem. And in more than half the cases, the individuals found to be in a crisis, and the police didn't just leave them there, but took them to a hospital emergency department for evaluation and treatment. And as a kind of unintended benefit, we found that the proportion of these respondents who were in outpatient mental health treatment doubled from the year before to the year after the gun removal action. That was our finding in Connecticut. 92% of the subjects or the respondents were men, median age about 47, although we had folks across the age spectrum. And they were men with lots of guns. On average, the law enforcement removed 7 guns per person in these cases. And importantly, when we matched the cases to death records, we were surprised to find that the annual rate of suicide was 40 times higher in a group of people than in the general population of Connecticut at the time. So what the law had accomplished by using this information that people had around them was something that's hard, for a computer to do, lots of big data, and that's to identify a relatively small group of people with highly concentrated risk. And so, if finding that person is a needle in a haystack, I like to say this gives you a smaller haystack with a lot of needles in it. And when we looked at the methods of suicide, we found that only a small fraction of them, while their ERPO's in effect, had used a firearm. And in fact, in Connecticut, no one did while that was in effect. A couple did afterwards, after they got the guns back. But so the firearm, of course, is the most lethal method, and none had used that during that period. So we used a statistical model to calculate how many more people would have died using the case fatality rate to estimate number of attempts, and then this sort of counterfactual analysis. If the guns had not been removed during that period, how many more would have died? And that's how we came up with this, for every 10 to 20 gun removal actions, one life is saved. Is that high or low? It might depend on where you're standing. If you're somebody who cares more about the Second Amendment than anything else on the planet, you might think it's unacceptable. On the other hand, the thing about ERPOs is that to implement them widely is that they don't have to be seen, and they're not, an expansion of gun control, because they don't affect the rights of law-abiding, non-dangerous gun owners one bit. They're focused really on people who pose this high risk at a particular time. So 2 years later, our group published a second evaluation of a second ERPO-like law in Indiana, essentially the same results, using descriptive data on violent crime outcomes, which turned out to be pretty rare. And just a little historical note, the Consortium for Risk-Based Firearm Policy, and I'm on their executive steering committee, was there when that was formed, in 2013, created the template for the modern ERPO laws that, many allow family members and sometimes others to petition for an ERPO, following the legal design of a domestic violence order of protection. And with the emergence of promising research findings, advocacy in key stakeholder groups, including law enforcement, and really a groundswell of public interest and demand, especially after the 2018 shooting at Parkland. These laws were passed in states now totaling 19 and DC. So what must happen now really is implementation, because they just have to be scaled up and widely used. If they're not used, you might as well just take your new bill and roll it up and put it in a bottle and throw it in the ocean, hope somebody finds it, because it's never going to do any good. So the promise has to be realized. People need to know about them. Courts and law enforcement departments need to be educated about ERPOs, have routines and protocols and infrastructures to process these and enforce them. Clinicians need to know about them, especially if in a state like Vermont they're authorized to do that directly, including things like storage and the timely return of guns to eligible respondents. And, the federal legislation, to come back to that, to support the states in these efforts, could help, just as the NICS Improvement Act helped states to dramatically increase their reporting of the records to the NICS system. So, just to finish, I'll say that ERPOs enjoy wide public support across the spectrum, as I mentioned, majorities of gun owners. They're not a panacea. They're an important piece of the puzzle of gun violence prevention. They would work better if we had other tools like comprehensive background checks and a better handle on the robust secondary and sometimes illegal gun market in the country, especially in some regions. But, they're a place to start. And I think, maybe they're the 1 square inch of common ground between earnest advocates of gun rights and gun regulation. So let me stop there. Thank you very much.
Great. Thank you, Dr. Swanson. So I just wanted to clarify, I think you said 19 states plus DC currently have ERPO. Do they all have the ability for law enforcement and families to petition the courts?
They do not. They all have the opportunity for law enforcement to do it. And I think about half of them have the opportunity for family members, and sometimes defined a little bit differently, to do this. But I should emphasize that, it doesn't mean, like in Connecticut, in our study, family members could not directly petition for a risk warrant, but most of the information came from family members to law enforcement. So, or from, close acquaintances and family members, household members. So it indicates that that's a lot of where the important information resides, and to facilitate that, to enable a family member to do that directly, seemed to make sense in the legal design of this.
Great, thank you. We have a couple other questions, Mari.
Thank you. I know we're talking about suicide here, but as you I want to extrapolate a little bit and ask you about the issue of dramatically rising workplace violence in healthcare settings, and if you're aware of any data about the use of firearms in those statistics.
So the data are emerging in the sense that we're conducting a multi-state study of the ERPOs in these 6 states that I mentioned have been coded in the common coding scheme, and the information is coded systematically. Where did it happen? Who was the target for it? So the short answer.
Dr. Swanson, you're going in and out again. I don't know if you've moved positions in your hotel room.
let me, can you hear me now?
Yes.
Yeah. So I guess the short answer is stay tuned, because that information exists in the multi-state study that's currently, actually we've completed, but we haven't published that yet. And I would say that, it's not a trivial amount of the concern when there are threats in workplace and, healthcare institutions. It varies a bit by jurisdiction in terms of where the ERPOs are being done, in part because the target population might vary depending on sort of, who's the champion for ERPOs. If it's being really implemented through a special unit in a prosecutor's office versus something else. But we need more information about that, and I would just say it's an important issue, and it's an important setting in which an ERPO, I think, could be a very useful tool.
Thank you.
Leslie?
Dr. Swanson, thank you. I was just wondering if you are able to give us your testimony in writing.
I can do that, yes.
Thank you.
Thank you. Please send it to Claire. That would be helpful.
I'll need to clean up my notes a little bit, but I can do that, yeah.
Great, thank you. Alyssa?
Yes, thank you. And thank you for coming in today. I just want to clarify, you were saying that in the studies you've conducted of certain states, did you say that your estimation is that for every warrant that is issued, you're suspecting that probably about 1 in 20 saves a life? Is that what you had said?
Yes, let me clarify that. That statistic comes from those 2 states, Connecticut and Indiana, and it's exclusively about suicide, because it's based on the number of suicide deaths and an extrapolation of what's called the case fatality rate. So, if a person uses a certain method, they're very likely to survive, and with the gun, they're not. So if the gun is removed and they try another method and they survive, you can estimate the number of attempts. So yes, for every 10 to 20, depending a little bit on the assumption that goes into the model about the likelihood that a male gun owner who attempts to end his life will use a gun if a gun is available. For every 10 to 20 of those gun removal actions, one life was saved by averting a suicide. And it doesn't include the benefit that might come from, as a result of this event and never attempting suicide. It only estimates the benefit that accrues to shifting the method of attempted suicide to less lethal means than a gun. So it might be an underestimate of the benefit.
Okay, thank you. And one last thing, I just wondered if you could very briefly summarize because I'm not sure everybody is in the committee actually is aware, but if you could summarize what around ERPO was in the Safer Communities Act on the federal level.
Yes. So the Safer Communities Act has Title I and Title II. And Title I is largely about mental health services and in schools and so on. And Title II includes some things having to do with firearms. And this one provides $750 million through the $1 billion through the $150 million through the burn JAG grants from the DOJ, and the states can use it for a number of different purposes. They can use it to implement things like mental health courts or drug courts or veterans courts, these kinds of specialty docket courts, but also they can use it to implement extreme risk protection order laws. So you could use it to develop training programs, to build data collection activities, to develop improving public awareness of ERPOs and the like.
Thank you very much, and thank you for coming in today.
Does anyone else have any questions? Art?
Yes, thank you for your testimony. I just want to clear in my own mind what we're talking about here when we talk about firearm removal. If an ERPO is done on a family member, are you able to remove firearms from the home or only prevent that person from purchasing a new firearm? How does that work?
Yes. So there are two stages of the NERPO typically. One is an ex parte order that can be done without the person being there because the situation is considered to be exigent, and it typically comes with a search warrant as well. And officers can try to do this in a way that is escalating and in a way that's respectful and trying to talk to the person, but they do have the authority to remove firearms from the home that the individual, the respondent to the to the ERPO has access to. So an exception would be, let's say that there is another household member who owns a firearm, but it's safely stored and locked up in a way that the individual who is the respondent cannot access. So then that firearm that's owned by someone else, if it's safely stored, that would not be taken. But guns that it can be removed. And as I mentioned, in Connecticut, on average, 7 firearms per case were removed from these individuals. And then, typically within 2 weeks, exactly what the Vermont statute says on that, but that's the typical ERPO, is that within a period of time, pretty shortly after the initial removal, there's a hearing at which the state has the burden, typically by clear and convincing evidence, to prove that the person continues to pose an imminent risk. And if they don't meet that burden, then the person, can get their guns back, and otherwise they typically will get them back within a year, although they can be renewed. These, again, they're based on risk. So that's typically how it happens. Sometimes there's the option that the person can, on their own, surrender their firearms, and there are some other options, but that's typically how it works.
And so a family member calls, they say, well, my family member has suicidal thoughts. The judge determines that to be something that warrants removal of the firearm. Is that how it worked? The judge?
Yeah. Yeah. Yes. Initially, the standard is probable cause in most states to
Right.
get the initial order, and it also prevents the person from purchasing or possessing a gun. So during the period that the ERPO is in effect, they are a prohibited person. There has been proposed legislation, at the federal level, it didn't pass, but wasn't included in the Safer Communities Act, to say that if somebody has an ERPO in one state, they shouldn't be able to go next door and buy a gun in another state, because that, is a possibility. And we do have examples of people who have died by suicide by firearms, notwithstanding an ERPO in place. So it's not foolproof, and it depends a little bit on the accessibility of firearms from other sources.
And is there any age limit on the person that gets requested not to have firearms? I mean, can I tell somebody my 35-year-old son shouldn't have a gun? I mean, I just wonder about the rights of individuals in terms of that.
And
protected through the person has the right to a hearing, and again, the state has to prove that the person meets the criteria that are pretty well specified. But the age question is a good one, because there are examples where the person of concern is a minor, and that's an interesting issue, because typically minors aren't supposed to have guns themselves anyway. But what this does is it allows firearms to be removed from the household if they're not secured, where a teenager or younger person poses a risk.
Thank you.
Great. I think we have one more question. Leslie?
Thank you so much for your testimony. I'm just curious about Title II. You said that there were funds for implementation for public health, whatever you call them when we do a public health blast. Where does that money, who accesses that money? Like from the state of Vermont, if we wanted to know how to do that, who at that level?
Public safety here in Vermont, really it would be the administration.
So the Department of Public Health, VDA. So if we decided to go forward, we could put into a bill that we wanted them to access something.
So it would be testimony we would want to take from them to see what
let's say
is happening
we wanted
today.
to do that. Yes. That would be I just wanted to know the path.
Yep, potentially. Yep.
Yeah.
Great.
Coming from HHS and on the mental health dollars are, but not the ERPO funds are coming through the DOJ. But like one of them, I believe, would expand SAMHSA block grants to states for certain kinds of things. And there's some excellent summaries out there of this program, including there's one on Senator Chris Murphy's website that summarizes these features. But yeah, it's something I would certainly hope that states can avail themselves of.
Great. Dr. Swanson, thank you so much for your testimony and being with us today. It was very helpful. And then when you can clean up your notes, if you can send that to Claire so we can reference it in the future, that would be great.
I'll do that. My apologies for the bad Wi-Fi.
Oh, no worries. We got it to work out. Thank you.
All right. Bye-bye.
All right. So now we're going to turn to Dr. Miller, and I am going to say this wrong. I apologize. Dr. Israel, I believe.
That's pretty good.
Oh, gosh. Good. Welcome. And Dr. Israel, we don't actually have you listed on our agenda. So what we're going to do is have both of you at least tell us who you are, whether or not you're going to testify, just so we know who's on the screen. And then Matthew, I've had a request that you don't share your slides since we all have it available so we can see your faces while we talk, if that works for you. Is that okay for you?
Okay, so I will indicate the slide that I'm speaking about.
That would be great. Yes.
Okay.
And then everyone, it is on our website. So what happens when you share your screen is we can't actually see you. And so we want to be able to see you. So, all right. So if you both want to introduce yourself for the record, that would be helpful.
Okay, my name is Deborah Israel. I'm a researcher at the School of Public Health at Harvard and a longtime colleague of Dr. Miller's. And I will, I think Matt will be doing our presentation, but I wanted to be available for the question and answer period if it were helpful.
Great. Thank you for coming.
Hi, I'm Matt Miller. I'm a professor of health sciences and epidemiology at Northeastern University. I'm an adjunct professor of epidemiology at the Harvard School of Public Health, co-director of the Harvard Injury Control Research Center, and I'm pleased to be here to share sort of what 25 years of doing research with Dr. Israel and others has taught me about suicide prevention.
Great, thank you.
Okay, so shall I begin?
Yes, please.
Okay. The first slide that you see has a picture of the 50 U.S. states and a picture of Ulysses, who is bound to a mast. I will get back to both of those and hope that that it makes sense when I do. So the one thing that I've learned over the past 25 years of doing research is that the single most important thing you can do to prevent people from dying by suicide is to reduce access to a commonly used, highly lethal method in that society. And in the United States, that means reducing access to firearms, which is to say that there is nothing that we know in suicide prevention research that can have a larger or more immediate or well-established effect on decreasing the number of people who are dying by suicide than reducing access to firearms during critical vulnerable periods. And that pertains to men, that pertains to women, and that pertains to children. What I'm going to do, the next slide that I'm going to turn to is the rationale for why reducing access sort of makes sense. And after I go through this rationale, we'll look at what I like to do, which is some data, the highlights of some of the data in support of this contention.
Great.
All right. So the second slide, rationale for means restriction. Suicide acts are very often impulsive and hard to predict when they're going to occur, but the crises, when they do occur, are often transient. The methods that people choose to use in a suicidal act largely depends on what's readily at hand. If you have a gun in the home, it's much easier to reach for that than if you don't. The case fatality rate, the CFR on the slide, that's the probability of death given an attempt with a given method. For firearms, you rarely get a second chance. With most other commonly used methods, the vast majority of the time, in fact, you do get a second chance. The fourth major bullet there, and if you look at the other commonly used methods like pills and cutting instruments, they prove fatal less than 5% of the time. So 90% of firearm attempts result in death, fewer than 5% of attempts with the most commonly used methods, cutting and pills, prove fatal. For people who survive a suicide attempt, we know they're at increased risk of going on to die by suicide compared to the general population. But to put that in perspective, if you survive a suicide attempt, your chances of dying by suicide is less than 10%. So yes, much higher than someone in the general population, but certainly not a foregone conclusion. When I was treating cancer patients at the Dana-Farber, during my fellowship, we had a new patient clinic. And what we wanted more than anything was somebody with Lance Armstrong's diagnosis, testicular cancer, because the prognosis that Lance Armstrong had with widely metastatic testicular cancer was that he would die. There's a less than 10% chance that he would die of testicular cancer. And so we should think about people who have survived with the same sort of optimism that we approached people like Lance Armstrong who had testicular cancer. And so the implication of that if you can prevent someone from reaching for a firearm today and save their life today, is that you very likely have saved their life in the long run. Okay, the next slide is the slide of the United States, that sort of variegated slide, which shows you that the rate at which people are dying by suicide varies a lot across the 50 states, about fourfold from places like Montana, where suicide rates are about 4 times higher than they are, for example, here in Massachusetts. Now, the next slide, which is a graph that has the states on the x-axis in tiny little print that you probably can't even read. What we've done is we've taken those 50 states and arrayed them from the states with the lowest suicide rates, like here in Massachusetts or New York, New Jersey, to the states with the next lowest, to the next lowest, until you get to the states that have higher suicide rates, like Vermont, like Montana, like Alabama, like Alaska, at the very end of the x-axis. So the states are marching along from the lowest to the highest suicide rate. What you see, and that's what the top black curve shows, suicide rates in a given state. What you see in the purple curve are the rates at which people in those states suffer from known risk factors, psychiatric risk factors for suicide. So, for example, rates of major depressive disorder. They're not higher in Montana than they are in Massachusetts. Rates of suicidal ideation, not higher. Rates at which people attempt suicide are not higher on the right side of this x-axis compared to the left side. People in Montana are not more suicidal, but when they make an attempt, they're more likely to die because they're more likely to use firearms, since firearms are present in their homes in great excess compared to Massachusetts, New York, and other states. Okay, the next slide is a meta-analysis. So it's a gathering of all the case control studies that were done, individual level studies, to come up with this sort of a grand estimate of how much higher the risk is if you live in a home with a gun compared to living in a home without a gun, from dying by suicide. And the grand point estimate here is about a 3-fold increased risk for people living in homes with guns, dying by suicide, compared to people living in homes without guns. The same basic assessment was when we did a cohort study recently in California. We came up with a very similar estimate of the elevated risk, the several-fold elevated risk. The next slide is a slide that says firearms and adolescent suicide, which I believe is a particular concern for the committee.
Yes.
And what this paper by David Brent indicates is that the odds of dying by suicide if you're an adolescent are 4+ fold higher if you live in a home with a gun compared to living in a home without a gun, after adjusting for differences between the adolescents who died by suicide and those who were living controls. So a 4-fold increased risk, very much in line with what we see at the state level from the graphs that I showed you. So all of these triangulate, all of these sort of are in agreement that if you live in a home with a gun, your risk of dying by suicide is much, much higher. The next slide is about storage practices. It's a paper by David Grossman. And what this slide indicates is that for children, these are 5 to 19-year-olds, if you lock a gun as opposed to having it unlocked, or you unload a gun as opposed to having it loaded, you're able to mitigate the risk of living in a home with a gun, not eliminate that risk, but reduce it from the fourfold increased risk down considerably less. Now, locking guns, if you look at the next slide, this is a study that Dr. Azriel, Dr. Saleh, and I published recently. What it looked at was how quickly adolescents who live in homes with guns can get to a loaded firearm and fire it if needed, per their own report. And what we found was that about a third of all adolescents living in US homes say they can get to a loaded firearm and fire it if needed in less than 5 minutes. About half of all adolescents in homes with guns say they could get to a gun and fire it within an hour. Locking the gun helps, in as much as it's, instead of it being a third of all adolescents, it's a quarter of adolescents who say they can still get to a gun in 5 minutes and fire it. So the key here is that the concept has to do with reducing access and how you do that. It isn't locking per se, it's access, which is why the effort that I believe you are making with respect to educating the public about the rationale for the legislation that you're crafting, that the education is critical, because it will emphasize, I trust, that reducing access is what will save lives, not merely locking it. Locking it is one of the pathways. But I really applaud you for thinking about getting that critical message about access across. The next slide is the one that says discordance. And what this slide indicates is that among the 70% of parents who said, no, my child, my 10 to 17-year-old child in the case here, my child cannot gain access to a gun independently, not without my help or his another adult's help, cannot. Among those 70% of parents who said that, and these are parents who live in homes with guns, 20% of their children said, I can get to a gun within 5 minutes. And a third of all their children said, I can get to a loaded gun within an hour. So parents don't know lots of things about their children. They don't often know that their children are going through really tough times. They don't know if their children necessarily are suicidal. They also don't know, they think otherwise about their children gaining access to guns in their home. Another sort of plug for the importance of accompanying the very sensible legislation that you've proposed across the board with efforts to get this rationale, the message across. And this second to last slide about does a gun in the home increase the risk of suicide? Well, this is a study by Dr. Azriel, myself, and a student of ours at the time, Andrew Connor, in which we asked a nationally representative sample of Americans, adult Americans, if they thought that having a gun in the home increased the risk that someone in the home would die by suicide. What you can see here is that among all Americans, people who lived in homes with guns, people who didn't, about 15% agreed that a gun does in fact impose suicide risk. Among people who lived in homes with guns, fewer than 1 in 10 agreed that having a gun in the home increases the risk of suicide. So again, it's really critical that you accompany, as you are planning to do, sort of your legislative efforts with efforts to get the message across. Because lots of people out there don't understand that if you can't put your hands on a gun in a suicidal crisis, you're not necessarily going to substitute an equally lethal method. And in fact, the data that I've showed you here strongly argues that most of the time you won't. And this last slide is a picture of Ulysses, who's bound himself to the mast of his ship. And he is at this time sort of surrounded by sirens who are trying to lure him and his crew onto the rocks. And what Ulysses did, aside from putting beeswax in the ears of all the people who are doing the rowing, is he had his crewmen tie him to the mast so that he would be able, so that he would not be able to act, right, when he heard the siren song luring him to death, he didn't anticipate that he would resist the siren's calls, that they would be less compelling. But what he did is he took preemptive steps, the kind of steps that you are trying to promote at the level of the population, to limit the actions that he can take in that crisis and to survive where others perished. So thank you very much for your time and for your efforts here. I'm happy to try to address any questions that you have.
Great. Thank you very much, Dr. Miller. Art?
Yes, thank you for your testimony. Do any of these studies make any distinction between a long gun, a rifle, a hunting rifle, and a handgun?
Some of them do. And what we know about the guns that are used in suicide is that overall, about 75% of the guns used in suicide are handguns, quarter are long guns. That's overall. If you look, for example, among women, 90% of the guns are handguns, 10% are long guns. But if you look at male adolescents, especially in rural areas, and this is I think this pertains sort of to many people in your state. If you look at male adolescents in rural areas, half of them use long guns.
Okay, thank you.
What other questions? Listen.
So I think I want to reiterate something because I had heard this earlier, and we've had a lot of testimony so far. I think it's really important if you could reiterate that suicide is not inevitable.
Right.
That it is often impulsive. And if you could just make that point again, I think we all have this version of what suicide is, which is not the reality. Much like your perception of adults thinking that their stuff is secure and their kids can't get to it.
Right. No, what you said is sort of spot on. You can always think about some suicides that are, you might describe as rational and deliberative, someone dying of Lou Gehrig's disease. But most suicidal behavior among adults, and especially so among children, is both sort of impulsive and critically. It's impossible to know when that crisis is going to occur. So you need to take preemptive action. I can't tell you when somebody we know is at risk for taking their own life will be at particularly acute risk and vulnerable to acting on that heightened risk. And so it is unpredictable, which is why doing the kind of things, doing everything you can to encourage parents, for example, to make their guns inaccessible to their children, not when they think the child is in a suicidal crisis, it's too late. But in general, because we want to protect our children, and although there are reasons to bring guns into one's home, there are risks that one is assuming for oneself as the gun owner, and in fact, imposing on everyone else in the home, and that you can mitigate those risks by making, for example, to the children, by making those guns inaccessible. Suicide is not inevitable. If it were, you wouldn't have the vast differences in suicide rates across the 50 states. The suicide rate in Vermont is twice that in Massachusetts because the firearm suicide rate is 5 times that. The non-firearm suicide rate is the same. Rates of depression and of other known psychiatric risk factors are not 5 times higher or twice as high in Vermont. They're basically the same as in Massachusetts. What differentiates with respect to suicide risk, Vermont from Massachusetts, is access to guns in the home, and you can do something about that. Does that capture?
It really does, and I thank you for highlighting the fact that that the suicide rate across most states, and particularly if we look at New England, that the suicide rate for non-firearms is essentially equal. and what distinguishes and what makes the difference between different states and different rates is strictly firearms. And
Yeah,
it's
exactly.
the difference in the firearm suicide rate that is what makes up that difference. And then I just want to,
Yep.
because I think that this is such an important fact. Just by virtue of having a gun in your home, your child is 4.4 times more likely to die by suicide than a child who doesn't have a firearm in their home. Is that what I'm getting from that?
Yeah, that's a correct interpretation of the Brent study, and one step beyond. If you, based on the Grossman study, you can mitigate that risk by storing the gun locked instead of unlocked, right? Unloaded instead of loaded. But you can't eliminate it, right? But what you can mitigate it, and the key there, and it just makes sense. The key there is to make it harder for the kid to get a hold of a gun and be able to fire it during a crisis. And that what you are trying to do is put barriers between sort of someone in that sort of desperate state and their ready and the ready availability of a gun.
Thank you.
Art?
You know how many suicides there were last year in Vermont that were caused by a handgun? Do you have that?
No, I don't. Sort of my guess would be it's roughly 75-ish% of the total number of firearm suicides, but I don't have that number. Does anyone there?
Sorry, Art, Alyssa can get that for you.
Okay.
We can get that data.
Yeah, and I asked this question of one of the other witnesses. Is there data showing an impulsive purchase of a handgun causing a suicide versus handgun in the home causing suicide?
That's a great question. That's a great and in fact really sophisticated question about the types of studies and the data that they generate. Some people sort of buy guns with the intent of taking their own lives that day or soon thereafter. Like, how do we know how many there are? I'll tell you what the data show. So there's a study published in the New England Journal by Arthur Kellerman back in 1992. So it was a case control study. And what he looked at was the proportion of people who took their own lives with guns, who acquired a gun within the month before their death. Okay. So, and what it turned out was that 3% of the people who died by suicide acquired a gun in the month before their death. We did a study in California recently in which we looked at new gun owners. So everybody started out in the study as living in a home where there were no handguns. As people acquired handguns, they became gun owners, handgun owners in particular. And what we found among the people who died by firearm suicide, about 15% of those who became new gun owners and went on to die by suicide had acquired the gun within that first month. Now, there are other people who own guns, what we call prevalent gun owners, people who were already living in homes with guns. And so if you were to ask the question, what proportion of people in California who die by firearm suicide die within a month of acquiring their first gun, it would be lower than 15%. And in fact, I've done the math, it's about 2 or 3% in line with the Kellerman study that I mentioned before.
Thank you.
Any other questions? Alyssa?
I just have one because I thought about something with Art's question. Do we have any data on just the national suicide rate during the time of the Brady bill, where there was a mandatory, I believe it was a 5-day waiting period? I mean, so that was national. Do we have any idea? And then I believe it was allowed to sunset. This was back in the 90s, maybe. Do we have any data on what the suicide rates were across during that period of time? And whether or not there was any decline or?
That's a great question. In fact, it sort of undergirded some of the studies that I wasn't here for Professor Morale's talk. I don't know if he spoke to the waiting period analyses, but it's that sort of question that motivated some of the studies, a study by Phil Cook and Jens Ludwig, and more recently some other studies. I don't think the answer to that question, sort of what happened to the suicide rate during that period, really addresses what I think you're asking is, does a waiting period save lives, right? That's what that you want to know. And so what happened over that whole time period, what happened to suicide rates could have been affected by lots of things. And these studies try to take into account sort of the other things that might have affected suicide rates. But they reduce, I think, if I'm understanding you correctly, to what's motivating your question, which is it likely that waiting periods save lives? And if that's the case, what I'll say, and I think Andrew will probably be able to speak more elaborately to the ecologic data, is that if you can, anything that you're going to do to make it harder for somebody in a crisis to act on that impulse at that time, you're going to save lives. And if a waiting period keeps someone who doesn't already have a gun from acquiring a gun during a crisis, you've done, I think, the most effective thing you can do to try to reduce that person's risk. And I don't know, Andrew, do you want to?
So I agree with what you just said, and would add that a lot of the studies that have looked at waiting periods have used that short period of a few years in the 90s when every state had to have a waiting period as part of their strategy for identifying whether these laws had an effect by looking at how suicides changed in all states during that period. That is a common source of information that has been used to establish the effect of waiting periods.
Thank you.
All right. Thank you all very much for your time and your testimony today. We really appreciate it. And if as we continue our discussions, we may reach out via email if we have any other questions, if that's okay. Great. Thank you all very much.